So cholinergic agonists, not a very exciting topic. Most have green caps, hence the green background here. These are the oldest of the glaucoma medicines. They've been around since the late 1800s and are also known as cholinergics, parasympathomimetics, which is a little hard to pronounce, and miotics, which is a term that I personally object to because it refers to a side effect of the medication, a little bit like calling carbonic anhydrase inhibitors tingly fingers. So I don't like the term miotics, but you'll see it all the time. Cholinergic receptors have both nicotinic and muscarinic activities. The nicotinic is edrophonium or tensilon. That's a neuroophthalmic topic that we're not going to go into. But the muscarinic mechanisms of actions are to contract the longitudinal muscles of the ciliary body and open the trabecular meshwork. And it's really the only glaucoma agent that increases trabecular outflow. So most people who have glaucoma, the reason that they have glaucoma is that fluid isn't flowing normally out through the trabecular meshwork. And so in many ways, this is the ideal class of drug. So just a reminder, going out through the trabecular meshwork into Schlemm's canal. They also contract the circular muscles of the ciliary body, leading to accommodation, which is a real problem in young people who have accommodative reserve. And they contract the pupillary sphincter, leading to meiosis. But the meiosis is not tied to the pressure lowering, and hence one of my problems with the term miotic. You can stimulate the acetylcholine receptor directly with drugs that mimic acetylcholine like pilocarpine and carbachol, or you can stimulate it indirectly by inhibiting cholinesterase, allowing acetylcholine to build up in drugs like ecothiopate iodide or phosphorine iodide and carbachol. So you see carbachol in both lists because it has some direct and some indirect acting properties. These are used for the open-angle glaucomas. They're really not used very much anymore chronically because the other classes of medications have pretty much supplanted this category. You can use it in narrow-angle glaucoma patients while awaiting a laser iridotomy. Having people chronically on pilocarpine because they have narrow angles, I think, is not a good plan. Partly because pilocarpine moves the lens iris diaphragm forward and can actually precipitate angle closure. Sometimes it's used to treat plateau iris syndrome. We use it pre-surgically for laser iridotomy to tighten the iris to put it on stretch. We tend not to use these in people who have active inflammation. You can, if you're on a cholinergic agonist, it can cause the iris to stick down to the lens and cause central posterior synechia. People who have high myopia are at some risk for retinal detachment in the face of these drugs. Side effects include chronic meiosis, and eventually the pupil will become fixed and unable to dilate. One can have brow ache from the muscle contraction in the eye. This is usually transient, and patients don't suffer from this long term. Accommodative spasm, so especially young patients can have multiple diopters of induced myopia from taking cholinergic agonists. And the risk of retinal detachment I already mentioned. In kids, indirect acting cholinergics like ecothiopate iodide can cause iris cysts, as you see here, and those same agents can cause cataracts in adult patients. They can precipitate angle closure, so they can allow the lens iris diaphragm to move forward and cause angle closure glaucoma. Systemic side effects are very rare, and they usually occur in the situation where one is over-treating during an acutely elevated intraocular pressure. For example, somebody who has acute angle closure glaucoma, Someone might put in pilocarpine drops every 5 minutes trying to get the pressure to come down. In reality, in that situation, you should lower the pressure first to a range where the cholinergics have a chance to act on the iris musculature. So these systemic side effects are often GI side effects, cramps, diarrhea. You can have enuresis. One can have bronchospasm. In the U.S., and unfortunately for any international students, I'm really only going to talk about what's available in the U.S. Pilocarpine is available in 1, 2, and 4%. Probably 2% is at the top of the dose response curve. Carbachol, 1.5 or 3%. Carbachol is used very rarely. The only time I use it is if somebody really can't get that fourth drop in a day. And then ecothiopate iodide, phosphorine iodide, is very potent. Unfortunately, it sort of comes and goes on the market. But for people who are poor surgical candidates who tolerate pilocarpine, ecothiopate can add to the effect of pilocarpine. And it's only twice a day, which is a real advantage. It's important to know that you should not use pilocarpine and ecothiopate together because pilocarpine will compete for the receptors and actually diminish the effect of the ecothiopate iodide. So pilocarpine is 4 times a day, carbachol 3, ecothiopate iodide is twice a day. We have recently had an ointment called pilocarpine gel that got rid of the 4-time-a-day dosing, but really had every other side effect that pilocarpine drops do. But I'm pretty sure that it's no longer on the market. I've read variable reports, and really it's hardly used anyway. So the key points: it's the only glaucoma drug that increases conventional or trabecular outflow. It is rarely used due to the QID dosing and the side effects. It can precipitate, or this family can precipitate, angle closure glaucoma. So it's important to know about cholinergics because you will run into them. You'll use them before you give people a laser iridotomy. But for chronic glaucoma management, they've really fallen off the map pretty much.